morning, everyone. Before we start off with the most important part of our conferences, the orations, there's an announcement which the organizing committee wanted me to make. All of you who are presenting, please load your presentations at the preview room. Don't get your laptops to the halls. We begin with the most prestigious oration of our society, the Dr. P. Shivareddy oration. I feel privileged that my term as president started by felicitating Dr. G.N. Rao and is ending with chairing the session. That's the most prestigious oration, Dr. P. Shivareddy oration, which is being delivered by the none other than Dr. Rohit Shetty. Just to say a few words about Dr. Shetty. Dr. Shetty serves as a young, charismatic vice chair of the Narayan Netralaya, Bangalore. He is an associate professor of ophthalmology, director of PhD program in ophthalmology with Maastricht University. He is also a senior research faculty with the Singapore Eye Research Institute. Dr. Shetty completed his residency training from St. John's Medical College, Bangalore, and has been trained at University of Mainz, Germany, and the University of Irvine, California. His main areas of interest are refractive surgery, keratoconus, neuro-ophthalmology, teleophthalmology, tears, inflammation, and biomarkers. Dr. Shetty has over 150 publications in peer-reviewed journals and loves to teach and solve complex problems. I request Dr. Shetty to come over onto the dais. I've been hearing to Dr. Shetty from the past so many years, and I think, I believe his philosophy in life has always been to question everything, not take everything at face value. That's what has led to innumerable new findings, which is helping the field of ophthalmology. And today, his topic for oration, question everything, I think will make us all also adopt that philosophy in life. Dr. Shetty, for you.
Thank you, sir. Thank you for this wonderful introduction, and thank Telangana Ophthalmic Society for giving me this prestigious Shivareddy oration. When Praveen asked me about what topic would I like to speak, I said my interest has always been about questions, and it's always the questions which lead you to somewhere. So my question everything for the next 15-20 minutes. The talk is on about what questions and how did it lead to answers. These are my financial interests, receive grants from companies and the government agencies for some of my work. The first person who said question everything was a great philosopher, Socrates, and that was his way of teaching. And one of the ways of that's why he became what he was during his time. His philosophy was he would never teach. He would ask his students to keep questioning him. That was a time when the questions, asking a teacher a question was considered not right or rude. And you can only listen to a philosopher. He was one of the first persons, I think, the philosophers of that era who changed the concept of questioning. And that's why the foundation of democracy, the foundation of the Greece, the way the Greece behaved after that, everything came shaped up because of those questions. And if you really look at this book, it's a very interesting book. If you're interested to know about many questions which people believed in, and many things they thought that that's how it works. 70-80% of things proved wrong. For example, there was a big thing about if the earth was flat, and some people believed at that point of time the earth is flat, it's not round. But there were a lot of people who believed in right things at that point of time, and they kept questioning. So what is the secret ingredients of question, and what questions we ask? The question's ingredient is always curiosity, to find something which we are not aware of, to find the desire of truth. And if you put that two graphs together, what you see in the center is the motivation, and that's for the science. That's how it's all linked. If you look at all these people, Edison, Tesla, Darwin, and Fleming, and even Socrates, I mean, there are many more I could not add into this slide. They all had the same passion for questioning. The interesting story about Darwin, about questioning, is he never started off being a scientist. And there's a book written by him, by somebody, saying he was one of the accidental scientists. That means we all read, we all have been told in college and schools that he went on HMS Beagle, he went to the Galapagos Islands, and he found, that's where he figured out that how the evolution happened. But most of us don't know that he did not go by choice, and he did not go as a scientist. He went because the captain of HMS Beagle was a depressed man. So his family wanted somebody who's a happy-go-lucky guy who could keep him company. So they said that at that point of time, all they could find, a happy-go-lucky guy who could keep the captain happy so that he would not commit suicide, because the captain had many people in his house committing suicide with depression. So he went there just to give a captain the company. And initially, when he went there, he was picking up all kinds of stuff which didn't make any sense. But suddenly, somewhere during that phase, made him believe that he's there for a purpose. And that's when he started questioning, and that's when he started drawing those birds, those odd organisms, odd animals out there. So it's not that you start off asking something. You can always become something in the middle. And we always see this picture of Darwin. It's completely different picture of him when he was young. And that is what the difference is. We all know the story about penicillin and how it was a discarded stuff in his in a sink, and how he figured out if somebody has discarded that, then probably we would have not had penicillin as early as it was at that point of time. The old model of disease is you have a disease, you take a pill, you knock it off, and you finish it and kill something. The cells, the organisms, bacteria, whatever you want to. It's a lock and key model. You know there is a lock, there is a key somewhere, and you fix it. But I think everywhere there's a huge debate that we have to change, and that change is started with cancer. When you start looking at the environment, you start looking at, instead of killing cells, you look at targeted therapies. When you look at targeted therapies, our present way of work just doesn't work for the targeted therapies at all, because we are not ready for it yet, because we are all in the skill mode. We use mitomycin, it kills the cells. We use cyclosporin, it kills something. There is nothing called a targeted therapy at all in our system. So that is what my question was. If I start sometime, probably in few years down the lane, maybe 2-3 decades, can we bring in a targeted approach in many, many things what we work on? You can look at genetics, you can look at prediction modeling, you can look at multiple things, but fortunately, everything is connected. We take it as one group. Okay, I'm a genetics person, I'll only look at genetics, I'll look at proteomics, but unfortunately, that is not how it is. It's all connected. Until you connect dots, everything looks completely different. For the next 10-15 minutes, I just have 4 mechanisms which I'll link at. Just a simple look at optics, a mechanism what we don't know for many diseases. The most important thing I believe in a questioning of something which is happening in a patient is his behavior, his psychology, his mindset, his psyche, everything. And how do you connect everything? So when we started looking at an optics of an unhappy patient, optics, what we read in school or our PG, is completely different than what we actually see in our practice. For us, the optics is the Snellen chart, the E, how much angle it subtends, and it's driven into our mind that if somebody can read everything, he is normal. But when we start practicing, we assume that if he's reading the last line, he has no problem to be in my clinic, or he should not be happy, he should not be unhappy. But that is where the big challenge comes. Questioning is, which we started some time back, is Unhappy 2020 project everywhere, whether it's dry eye, refractive surgery, cataract surgery, because we have to come out. The big question was, how do we come out of that mode of being in so fixed on the Slennon equity chart? Because that is what I think is putting us down in today's practice, because we are not looking at the quality, we are looking at the quantity. If you're reading this is also 2020, this is also 2020, but there's a huge difference. And if you're not understanding that, then it's going to be a disaster. So when you look at optics, all this forms an important integral part of optics. And most important thing for me in today's world is tears. And tears as an optical element has never been taught to us. And we have never been told that tears can also be a most important optical element, because it's the first refracting surface. I call it as the phantoms of your visions. You have it, but you don't see it. But if you don't see it, you think that it does not exist. It's just a phantom. One of the most commonly found problems of post-operative multifocal glare in my project of 2020 was tear film. And every person who had problems or who wanted to explant the lenses, everybody had this problem. So we started looking more deeply into the tear film. And there are tools today which looks at your layer of lipids and how you can see that on the other side how the tear film is actually scattering. It's like your T-butt, but it tells you in a diagrammatic way how the T-butt, which is when it's breaking up, how the optics is changing. So that shows that there is 70% of those who are unhappy with glare have this kind of a tear film. So you just have to take care of the tear film. The second question I always wanted to know is, the devil is in the cylinder. So whether you are a refractive surgeon or cataract surgeon, it's always your cylinder which is your problem, because your cataract surgery can bang on treat the power, but it's a cylinder when you start getting problems. The question always is, we always assume the cylinder, whether you're doing for a cataract or surgery, comes from your curvature. So we started off with the lens biophysics model. It's a mathematical model to understand how much does the cylinder and what is a real cylinder and your astigmatism. For example, let's look at this patient. He's got a close to no cylinder, astigmatism is 0.4, but he's accepting a 1.5 diopters of cylinder. The question is, where is this 1.5 diopters coming from, and why is he using this? And why should he use that cylinder when the cornea is not having it? This is what is being told to us. You have a flat axis, you have a steep axis, your K1, K2, and that's what your cylinder is, with different axes, with bid rule against the rule. But as we keep moving on and understanding optics in different way, if you decompose the cylinder, it's astigmatism. The cylinder is just not your curvature. It has also other things. Your other things could be your coma, your higher order astigmatism. This is regular. That means patient, whatever you do, whether you put toric, you don't put toric, perfectly everything gets well. But if you don't understand this, what happens is each of them are acting in different axes. The coma is acting in different axes for the same patient. The trefoil is acting in a different axis, and you virtually end in a completely different axis what you don't want to. So what happens then? And who is the person who's actually helping you to see better even with such kind of chaos? That's when we started looking at internal. So there are new tools, like Osiris is a new tool where you can look at real-time accommodation. What you see, that red thing seeing there is a real-time accommodation. And how does a real-time accommodation change with each person? What's very, very surprising, and what is not more than surprise is the interest, is the accommodation is a signature mark for every individual. I've studied more than 1,000 people on accommodation of different kinds. There's no two different accommodation which is the same, how the lens behaves. But what has been told to us in our college and our books is that accommodation and theory of accommodation as though it is the same for every single person. And accommodation changes with your mind, your moods, your work, your emotions, and it can change. I've done series of work, and this is what happens in a normal one. But let's look at somebody, and this is just an animation. Let's look at this. What happens is, you can see that at some point of time, you can see that kind of accommodation where the lens is only tilting in one direction. The red area is the area where it's tilting in one direction. And this is something which we have never known. The books don't tell us that the lens can actually work like that's why the adaptive optics, or the optics where the lens manipulates according to the light, that's used in telescopes. Somebody must have known this, and they use the same kind of tilting of those lenses which adapts to the scenario and situation. And that's why these are used in telescope. I think human system is much better than that. This is why whatever you do on cornea is very forgiving, because the lens kind of adjusts according to it. It's a very adapted thing. For example, instead of accommodating normally, what it does, it kind of tilts itself. It kind of balances itself in a much beautiful way. This is what the question is, that toricity is not just your curvature. The toricity also includes your aberrations. In this, if you put a toric lens, you may get a bang on. But in this patient, where the coma is predominant part of your cylinder, you may get a completely different thing, because the cylinder of coma and astigmatism are two different axes. So that's why sometimes you may never get an axis proper, or you may put a toric lens, but you will have something else the next day. But that is where the challenge is. So understanding optics is probably the most important thing in the next wave of our refractive cataract surgeons. So the second question is, our topographies are not perfectly aligned to teach us everything. So we started asking, can we make it better? Because epithelium masks everything and virtually covers up everything. So there were people who would take the epithelium off, take the patient back to the outpatient and do a topography and do it. The question we asked is, can we do without this? Because we work with a group of very smart engineers and mathematics driven people. So what we started doing is, this is what we published. Is the first publication of a virtual Bauman's topography. That means virtually to take the epithelium off without actually removing the epithelium, and it do the topography from your OCT from the epithelium. So what happens is, I'm not going to the details of it, but a lot of mathematical things involved, and you can do a Bauman's topography, which we use it in many, many places in our practice. And for example, you can see this is from the pentacam, and this is the epithelial thickness from the OCT, and virtually you take it off and you get a different topographer, and this is a true topography because it is going to be without masking effect of a pentacam. So how good are we? Because the question comes as, it's anything when you do a mathematical stuff, people always ask, is it really accurate? When you compare this is the same patient when you really did the epithelial removal and you did the topography, and this is a virtual. And you can see that they match very closely, and this is something which we are writing it as a publication now. That means the virtual mapping is as close to as removing the epithelium. The second part is, how do you get into the things when the mechanism is unknown? For the interest of time, let me just use only the dry eye, because and in that dry eye, the biggest problem for all is not treating the dry eye, but the pain, where we don't know what really happening because nothing works for them. This is a very good paper by Annette Galler, her group. I think she pioneered the concept of neuropathic pain in the eye. I think if there's nobody in the world has worked more than her on neuropathic pain. Virtually in the eye, everything pain, she is there. And she says that there is such an increase of symptoms and signs of disease are not matching together. It's becoming a big pain to all of us. It says as pain without stain. Even the Deuce 2 classification has added this neuropathic angle in a different way this time, because they want to believe that this is something new. So what we started doing is, also being a cell biologist, a bit of cell biology interest in me, I started collecting the tears of all the patients who complained of pain but did not have signs of a dry eye, but T-Bud, Schirmer's, and all the meibomian glands were all normal. So we called it the biomarker project, and this is how the process of collection, sampling, all this was done in the lab. And we started, once you have a sample, you can extract anything out of it. It's like having serum or blood. If you have blood, you can virtually get anything. Tears is, I feel, the tears is going to be the next serum in the 5 to 8 years from today. You'll virtually get everything out of it much easily without poking anybody. So there are pro-nociceptive fibers, pro-nociceptive molecules, and the anti-nociceptives. Life is a balance of pro and anti. Virtually, you can't knock one off, we'll all die. Because if something touches you, you should know it's a pro. That means it's telling you that somebody is hurt, something is hurting you, something is poking you. What really happened is that balance suddenly changes. And here, what happens is the anti-nociceptive and the pro-nociceptive balance, these are the markers of all of them. And this is from cell biology from everywhere, from skin to toe, they're the same molecules. There's nothing special in the eye. So what really happens is, those are those pro-nociceptive fibers, and those are all your nerves. Nerves have those mediated factors, and these blocking agents start targeting the corneal nerves, and they start hyperpolarizing or changing their whole polarization effect. And that's when the patient starts saying that, I go out, I see the light, my eye hurts. When somebody speaks loudly, my eye hurts, because even when somebody is speaking loudly, there are waves formation. There's a wave, there's light, everything create a trigger. And these factors are so sensitive, they trigger so much that it completely imbalances everybody. There was an ophthalmologist recently I saw. She wanted her tears to be examined because she has exactly nociceptive pain. And she had such high level of pro-nociceptive factors. I told her that your problem is pro-nociceptive factors because it's so high. And we assumed that everything happens only with the eye. When she told me that all her life, her skin was sensitive because touch, feel, or even a small thing has more pain than normal people. That means in the whole body, maybe the sensation may be completely different. And this is exactly what happens in a practice. The big question is, knowing this, our drugs don't work. Even though there are so many drugs, even the new Zedras and everything. That's because we don't know which pathway it's working on. Just because Zedra is a new drug, it works on a molecule called ICAM1. ICAM1 is not the major culprit in all the dry eyes. But if you use it for blanket as everybody, it's like VEGF. VEGF may not be high in all the retina patients for diabetes. It may be something else. It may be angiogenin or ICAM. But if you are injecting for everybody, that is not the targeted therapy at all. We also worked on many vitamins. We were one of the first papers on vitamin B12. That time it was difficult to prove that it was there, but it was accepted. When I started talking about it, many people were joking with me that saying that everybody in India has vitamin D deficiency, so everybody should get vitamin dry eye. That's something which sometimes is a wrong concept, because having a deficiency or having a genetic deformity does not make you have a disease. To have a disease, you have to have this. This is from a cancer biology. That means you should have the disease, you should have the genetics, and you should also have the host to behave. This is taken from a lung cancer work. That means your host response is smoking, and you smoke more, that is your disease specific, and you should also have a lung cancer creating gene. If you have all the three things, only then you will start manifesting. Vitamin D exactly works the same way. There are genetic deformities of vitamin D receptors, which is a gene defect. The patient may express this gene defect, and he may be deficient. You have to have all the three in equal amount, only then he comes to you, and then you treat him, then it becomes. So that is why 80% of the population who are vitamin D deficiency or any other deficiency do not manifest a disease. That is why people who smoke 100 cigarettes do not manifest lung cancer, because he may have only one of the factors there, the other two may not be there. So this is the answer why it works that way. However, when you have a question, you have to publish. There's no space in this world today to have personal anecdotal experiences and keep moving about it. And we started publishing, and the world started publishing now, and there are many, many more publications. What if the question is, if your cell biology and the mathematics could speak to each other, because that's how its body is made, your mix of cells and mix of mathematics. And that's what the first question was, is it inflammatory? We started working with different groups of people who are not just ophthalmologists, they're mathematicians, scientists, and everything. This was the first experiment 10 years back, and many, many questions, and also part of my PhD. I started looking at if the disease is localized. So every time you have a disease, you keep asking more and more questions and more questions and keep publishing. This is a new question which we wanted to ask. When you remove an epithelium, all epithelium of a PRK don't come out the same way. Some are very loose, some are very tough, but we don't care. So what we started doing is, every time we used to remove an epithelium, we asked the question, is the markers different? And we started writing there, okay, loose epithelium, hard epithelium, strong epithelium, and we used to write in the file, and each of those epithelium were stored and taken into the lab, and we analyzed for many markers. Very interesting thing emerges that whenever you have a very loose epithelium, the eye inflammation was very high, the pain was very high, their healing was slower, and they would end up in more haze. So whenever we have a looser epithelium, our protocol of treatment would little change. We'd probably give them more steroids, keep them more, call them more often, maybe use doxycycline, keep them on a cyclosporin, because this is the markers from them. All the markers of inflammations were many, many fold higher in a looser epithelium than this. So that means virtually you can look at every single question in every single every day in your practice, if you're just aware of that, being in that moment. Sometimes we are not in that moment, sometimes we may miss these things, and many, many things can be done. The last part of my talk is about behavior, which before getting into ophthalmology, I did not complete my degree, but I did partially psychiatry. So I apply a lot of psychological aspect to practice, because today we need that, because we are not assessing the patients at all. If you go and apply to a job in a company, they assess our psychological aspects more than our CV, which we don't do it in our practice. So why are some people happy and some people unhappy with your surgery or with you or with your practice or whatever? It's just your personality. Some people are 660 or less, but they don't crib. Some people have a residual power of -2, but they're very happy. They speak to you nicely. And we wonder, what is so much of a difference between two individuals? And why is the other one who has a perfect vision not happy? It's just the personality. So what we started doing is, there are a lot of personality evaluating scores, but some are very, very tough. So it takes a long time. So we just used the small score and started giving a question. What is very interesting is, the outcome of a person was determined by the type of personality he or she had. Like, for example, you may have a different type of personality, and that personality is something. We're just writing this up, and maybe I'll send you the papers if anybody is interested. Personality is the most important thing, especially when you're doing something complex. Your bacteria are driving the disease today, your placebos, your faith, and gut microbiomes. The things which we don't know or don't bother are what is going to drive this disease. So finally, to connect all, it's all between the cell and the mathematics. And we have to know this, not the way we were trained, not the way we've studied, but the new way of looking at it. A new way we have to adopt, and as faster as possible, because these are the genetics and epigenetics factors which can drive any diseases of the future. Tears, like I said, is just not with the dry eye, virtually a lot of it, including cancers. We personally working on a kit which the first prototype will be ready hopefully by July for inflammation and VEGF. And this will probably be a point of care kit where we can assess in your outpatient. It will take a few years for it to become reality, but at least a beginning. So finally, we should love science, whatever we do. And this is a very important book which tells you how to be curious in all that you do. And all that most important thing is, it starts with curiosity. And whenever you're asking questions or whenever we are in that process, we should never forget that there's an ethics. And whatever study we do, even the Shermer strip which I preserve, the patient has a right to say no. And I've had only one patient who said no to preserve the Shermer strip for studies, and we did not. So ethics is very important in today's practice. I thank my team and many, many people and all the seniors and a lot of friends who have given questions and inspiration to keep answering. Thank you.
Thank you, Dr. Shetty, for giving us an insight into the type of results we can elicit by proper inquisitive thinking. I would like to request you to accept a small memento on behalf of TOS.
In Sarojini Devi Eye Hospital and to see such a festive and scientific atmosphere. And it's a great pleasure for me to introduce Dr. Mandal, who's been a good friend, and I had the opportunity to be with him for 6 years and enjoyed his company. He's a very dedicated, committed person, and it's very difficult to see anybody with so much dedication to his profession, patients, and colleagues. Dr. Anil Mandal is a glaucoma specialist with particular interest and expertise in developmental glaucoma. He trained at the University of Calcutta at the All India Institute of Medical Sciences. He completed his fellowships in glaucoma and emergency ophthalmology at AIIMS. He's a visiting research. He had done his research fellowship at Kellogg's Eye Center and Doheny Eye Institute. He has won several national and international awards and has published widely. His research focuses on the clinical and genetic aspects of glaucoma in adults and children. And he's the first ophthalmologist to receive the prestigious Shanti Swarup Bhatnagar Award for Excellence in Science. And he is a fellow of the National Academy of Medical Sciences for his contribution to science and ophthalmology. He is synonymous with childhood glaucoma worldwide. That's his academic persona. He's a great poet, and he, as I told you, he loves his children. I mean, after 30 years of practice also, his old patients, he's created a group wherein all the parents and the childhood glaucomas, what he has treated, every year they come, meet him, and he has a day, something like Children's Day Out. So that's the commitment he has. And he's always Dr. Manchi. For all his patients, he says Manchi, Manchi, and then he's Dr. Manchi now. So, Dr. Mandal. Thank you.
Using me for this oration, which honors Dr. Rustom Ranji, who is a great ophthalmologist. He was ophthalmologist to the former Nizam. He was a chartered member of, Lions Club of Rotary Club of Hyderabad. I am honored to present this oration. The title I have given, Congenital Glaucoma, My 30 Years Experience. So my journey started in All India Institute of Medical Sciences when I was working with Professor N.N. Sood, my mentor, I'll come to this story later on. Now, congenital glaucoma is a very rare entity, but of all the childhood glaucoma, it has been proved that primary congenital glaucoma is the most common variety. The picture you see here, the marriage ceremony I attended of a girl whom we operated in the year early 90s. Dr. Pradeep Sarup, probably in the audience, is here. He was there in the operating room while I was operating on this child. This is the photograph taken 25 years ago when, in spite of my best attempt, I could not elicit smile on the face of the parents. I explained that the disease is mild and I have confidence that it will be all right. It brought smile to the parent's face only when, after 2 months after surgery, the child's cornea cleared. And just compare and contrast the photograph at presentation and about 2 months after that. Here is the photograph, the child after 25 years, and this year, few months ago, I attended the marriage ceremony of this child. You know, if we consider the history of management of congenital glaucoma, about 60 years ago, this statement was written, the future of children with hydrophthalmia is bleak. Yes, this is the clinical appearance typically, and here is the situation. The parents are in great trouble. And if the tears of this little child move you, they are a window open onto the sea for what you feel are not merely the tears of this one child, but of all children. The diagnosis, investigation, the recent advances in the medical and surgical management had improved the prognosis of this child, and along with that, the genetic understanding of the molecular basis of the disease has helped us to study the disease more carefully. Of all the surgical options available or listed here, with very valid reason, we used to perform primary combined trabeculotomy, trabeculectomy, which I learned from All India Institute of Medical Sciences from Professor N.N. Sood. Here is a paper in 1983, his first paper published in Indian Journal, where he commented that this surgery is probably the safest and the most effective technique in Indian patient population. An editorial in the British Journal in 1994 expresses the same view, and this may represent the next step in the search for the best surgical treatment in the management of congenital glaucoma. We reported our 15 years result in the journal Eye, and here is the survival curve. I am presenting this latest statistics here. The sound is not coming. 1,128 eyes of 653 children were treated, and here is the situation. The surgical technique I am presenting here, the primary surgical technique is combined trabeculotomy, trabeculectomy. Under a partial thickness scleral flap, the Slem's canal is opened, and once that is done, the trabeculotomy is performed on each side of the radial incision. This is the most important step of the microsurgical technique and should be done under higher magnification. Once about 80 to 90% of the probe is in the canal, it is rotated to create a continuity between anterior chamber and part of the Slem's canal where the trabecular meshwork is disrupted. After that, the trabeculectomy part of the operation is performed and the surgery is completed by closing the scleral flap and then conjunctival incision closure. Here is a situation, just compare and contrast the audiovisual people. Can you work on the sound system? It's not working. What we are seeing here is at presentation 2 weeks, 2 months and 6 months postoperative appearance. Here is the clinical appearance photographed after 6 months of the surgical technique. And you can see here just compare the upper panel of photographs with the lower one. The photographs were taken at 10 days interval. The 3-month-old child presented with acute hydrops with congenital glaucoma, and we operated. Simultaneous bilateral surgery was done, and 10 days after surgery, the corneal edema cleared. This is a photograph taken after about 25 years of surgery. You know, the Habs striae becomes so thick as it is seen here in the anterior segment OCT photograph. Here is the child, you know, came at the age of 3 months with acute eye drops, and after operation, the child's behavior, the child doesn't want to go to the mother. Here is the situation. We have influenced the child so much. Momentarily, he is refusing to go back to father's lap. And look the appearance of the child's behavior. This child's operation was performed about 7 years ago, and the child is studying 4th standard now. The child aspires to be a doctor. Here I am presenting his story published in New England Journal of Medicine, and here is the child along with the parents, the child seen along with me in the OPD. We did several studies to assess the quality of life of the caregiver as well as children with congenital glaucoma. Here is a set of questionnaire to assess the caregiver's quality of life. And here is the presentation where preoperative and 6 months postoperatively how the quality of life of the caregiver has improved significantly. Here is a child operated at the age of 2 weeks. This is the appearance at presentation, right and left eye picture, and this child seen at the age of 3 years. And here is the child, you know, singing in the OPD, which I photographed, a videograph. And here is the child seen after about 24 years after surgery. The child is studying in University of Waterloo, computer science, and here is the child. The father was giving an interview along with the child. I'm not going into that. Coming to my journey started in All India Institute of Medical Sciences. I had an opportunity to work with Professor Sood for 3 years after passing my MD in the year 1986, yes. And Professor Sood is the reason I entered glaucoma. He was the chairman of the glaucoma department while I was a postgraduate student and later on senior resident in the department of glaucoma. I owe to Professor Sood all my professional skill, for he is my Guruji with unflinching stewardship, erudition and expertise. Professor Sood is an orator of rarity, a writer of an unusual grace, a complete artist as a surgeon and a deep religious man. I shall say in no uncertain terms that he is my Guruji, and each time I operate on a child, I remember him. This is the child who inspired me to do congenital glaucoma work. In the year 1988, the parents from Hyderabad took the child to All India Institute of Medical Sciences, and Dr. Sood operated on this child. I happened to assist Professor Sood, and here is several photographs of milestones of the child. I attended the marriage ceremony of this child, and here is the child seen 6 months and at the age of about 27 years when he got married. This is the child I operated, came along with her husband, and here is the group photograph taken in the OPD. When I was working in All India Institute of Medical Sciences, I decided that I'll do work on congenital glaucoma. After joining L.B. Prasad in the year 1990, our founder director, Dr. Rao, asked me to concentrate on a disease where all surgeons will be referring to me, and I decided to work on congenital glaucoma. Dr. Balasubramanian inspired me to do an integrated approach, integrating medical, surgical, genetic, and rehabilitation approach, which gives the holistic care for child with congenital glaucoma. And in the institute, we are carrying forward this work. When I look back, my work for last 30 years, I believe influence of my professional activity and compassionate therapy on children with glaucoma is impactful. Of about 2,500 children operated by me in the last 28 years of my work in L.B. Prasad Eye Institute, 3 are medical doctor, 6 are dentist, and 3 PhD. Several children are now in computer professional, law, journalism, engineer, teacher, etc. I'm giving an example. The girl you see here, operated by me, is doing internship in Nagpur Medical College. The girl seen here along with the parents and me completed internship. Her right eye was more severely affected. With the help of left eye with telescopic magnification, completed the MBBS and internship, planning to do psychiatry as a post-graduation, as subspecialty. So, here is a child whom we operated. The father is a surgeon. This is he is a student of 5th year MBBS now, wants to become a surgeon. Now, this is the brighter part of the story. And here is the story where our results are not very good. That is because of the very severe affliction, most severe form of the disease. Now, how to take care of these children, along with the Department of Sight and Enhancement and Visual Rehabilitation, Integrated Management has really given an opportunity to the children and the parents so that they are still happy. I'm giving few examples here, lived experience in patients with congenital glaucoma seeing through their eyes. Here is a child. Audio would have been better, but let me explain the situation. We operated on this child. We knew that we cannot do probably, produce excellent result, but I introduced the parents in the Center of Sight Enhancement and Visual Rehabilitation. The child completed 10th standard from the Devnar school here, and now studying 11th standard. The mother is giving interview here. The child is very fond of, singing, and here is the child seen here in the OPD. Another child, here is the child. The child of a child whom we operated in All India Institute of Medical Sciences and then at L.B. Prasad Eye Institute after several years when the child was 10 years old. When I was dealing with this child, the lady here by my side, by my left side, is the patient whose operation I assisted, Dr. Sood operated, and after I left All India Institute of Medical Sciences, he operated twice more on each eye, so 3 surgery each eye, and by the time the child came to L.B. Prasad Eye Institute, left eye was the only eye, lost complete vision in the right eye, and we operated on the left eye once again for the 4th time to improve the quality of vision because there was still corneal edema and high pressure. When the child was seen here at the age of 10 years, we operated, and here is the child, could draw my cartoon here. Just compare and contrast the creativity of a child afflicted with severest form of the disease and side by side the picture of the artwork of a child, normal child. Here is the child giving, here is the mother giving interview, and when I was asking her how you feel about it, she expressed her greatest happiness that the child is not afflicted with congenital glaucoma, and by 2-meter vision, the child completed, the mother completed and scored 92% marks in 12th standard, completed BCom, and she was the topper in MBA exam. When the question of childbirth came, the whole family asked me what will happen to the child. I said, let us wait for the child to come. And fortunately, the child was all right. And when I was dealing with the child, I was having a feeling very well expressed in the proverb, seeing once again in the wonder of birth, life comes to a full circle. The girl has become the mother, and myself and me as he become grandfather. Here is the child interacting with interacting with me. Children, our greatest inspiration for the present, best hope for the future. We are guilty of many errors and many faults, but our worst crime is abandoning the children, neglecting the fountain of life. Many of the things we need can wait, child cannot. Right now is the time, his bones are being formed, his blood is being made, and his senses are being developed. To him, we cannot answer tomorrow, his name is today. As is the very definition of the child, so is the disease, childhood glaucoma, particularly congenital glaucoma. It's an emergency situation, surgery should be performed at an early age as possible. And whenever I approach a child with developmental glaucoma, it inspires two feelings in me: affection for the way he is now, and respect for what he or she may one day become. You know, I'll present the video here. The child is dancing. 11-month-old child whom we operated is performing, the dance. I took help of his elder brother, and imitating elder brother, the child is dancing. You know, just enjoy the child's behavior. Just learn the art of walking, and the child is performing here. You know, when I react or interact with children, it reminds me of a statement. A few decades from now, it will not matter what my bank account was, or the kind of car I drove, or the sort of house I lived in, but the world may be different because I was important in the lives of few children. Thank you once again for this opportunity to address you with the Rustom Ranji oration. Thank you.
That was great. Thanks, Dr. Mandal, for
Thank you.
the insights. And he's a great poet, and he's an excellent surgeon. His surgical photographs are just like textbook pictures. I really greatly admire him for that. Thanks, Dr. Mandal.
वीडियो नहीं चले भैया, ऑडियो नहीं आया।